Yeah. Dr. Gopal, you're on mute. Dr. Gopal, you're on mute.
Minute, sir. Am I audible?
Yes, audible.
Yeah, now yeah.
Good afternoon. Thank you, Dr. Suresh, for the presentation. In this IPS-KC KCPG conference today, I would like to my team led by Dr. Satish Ramaiah, who is Executive Director of Health, and Dr. Smitha, who is the Center Head in the Bangalore, Sukoon, and the case presenter, Dr. Vishakh, who is a consultant psychiatrist in Sukoon Hospital. I welcome the team. And for today's case presentation, the topic is the triad of care, navigating legal and cultural currents in acute psychiatry, challenging case of 24-year-old. State the opening statement. Thank you.
Unmuted, right? Yes. Hi, good afternoon, everyone. Thank you, Dr. Gopal Das, for the introduction. Hello, everyone. And first of all, at the outset, I would like to thank IPSKC and Dr. Suresh for this opportunity. Being in a private psychiatry, I know normally it's handled by medical colleges, all these case conferences, but we really academically oriented and wanted to have this opportunity to discuss about interesting case with PG students. Thank you for that opportunity. So I think Dr. Gopal Das is traveling. Maybe many of you may not have heard some of the things he said. I head clinical services at Sukoon Health, and Dr. Smitha Manjunath is the center head here. Dr. Vishakh is one of the consultants. Now, today's case conference is a little unique because it's presented by private psychiatry, and also I would like students to use this opportunity to maybe explore how the private psychiatry practice will be compared to government or medical colleges and other private practices in an inpatient setting particularly. Because uniquely what we face here is apart from the the legalities of the clinical challenges and stuff, the way the whole expectations that are there from the families and other stakeholders would be slightly different here. There will be sometimes a sense of entitlement, and also the whole clinical care, how it's provided. Not that it is different, but I feel we have to navigate it in differently. It has to be a lot more robust because of the commerciality involved here, and also the expectation aspect. And many times we do come across a lot of challenges in many areas, not just clinical, the legalities of managing the consent aspect, the capacity aspect, and so on. I think this particular case will give you a little flavor about all these challenges in private psychiatry, particularly in acute psychiatry, in the inpatient setting. So Sukoon Hospital is primarily into acute psychiatry. In Bangalore, we have this 22-bed acute psychiatry facility. Little premium in approach in terms of infrastructure, clinical team, clinical program, and also we also monitor the progress of the patients through clinical outcomes on 10 different parameters. So these are some of the ways we work here. I think when we discuss this case, you'll also get a flavor of how the multidisciplinary team and the clinical program is here. So that also will be a good learning, I think, for the students, and we expect interesting and stimulating discussion. I'll just let Dr. Smitha to say a few things about this case before we ask Vishakh to present.
Good afternoon, everybody. So what I'd like to say is, this is a patient who was admitted with us. She's now discharged, and she has been in follow-up with us for some time. But this patient was unusually challenging for us in a lot of ways. And across all of us consultants who have worked here at Sukoon, we have all wondered at various points on her diagnosis. We wondered where developmental issues ended, where Axis 1 issues started. We have wondered how to handle a family with respect to their expectations from not just the treating team over here, but also with their expectations across continents. And as Vishakh presents the case, you will realize that this is somebody who has been exposed to various mental health service delivery systems in different continents, in Europe and here, and we get to see how we contrast with each other. We also will get to hear a little bit about how the principles of autonomy and least restrictive care come into play with respect to the sections that we admit patients under. Very interesting, has been the topic of discussion amongst all of us for a very long time, and we wish to share this all with the rest of you listening in. So let's start. Dr. Gopal, can we start?
Thank you, Dr. Smitha. And now I would like to invite Dr. Vishakh to proceed with case presentation.
I hope everybody can see the screen, sir, and I am audible.
Yes, you are audible.
Yes, Doctor.
Yes, right. All right. Most of the things, I mean, while we go on discussing about the case, I'll be presenting about what are the clinical challenges, legal challenges, and cultural challenges that we faced with this case. And one more thing is, this will not be a usual case presentation that postgraduate does, because most of the information, I've given all the relevant information, but maybe I've missed out some of the headings. Okay. So she's a 24-year-old female, originally from India, but she is living in Netherlands from the age of 9. She's pursuing her master's in liberal arts, and she lives with her partner in Netherlands, and she's comfortable in English and Dutch language. Right. So I'll start. Right. So I'll start. So the way I'll present the case is, it will be like a story. So I'll start from how the symptoms began and how it progressed over a period of time, and how we admitted her. It will be like that. So when she was in Netherlands, from the age of 16, she was seeing a psychologist there for various things, that she had IPR issues with her boyfriend, with her parents. Emotional dysregulation was there. She found it difficult to cope with academics. So for all these reasons, she was in touch with a psychologist from the age of 16, 17. In November 2025, the psychologist felt that she needed assessment for diagnosis of ADHD, and she was referred to a center there which usually manages ADHD patients in terms of evaluation and treatment. After the evaluation was done, they concluded that she has ADHD, and she was started on methylphenidate 30 mg in divided doses. After a week of starting this dosage of methylphenidate, it was observed that she started talking a lot than usual. The way her sleep-wake cycle got affected, she became irritable and more verbally aggressive. And she was actually working on her thesis, and the way she planned to work on it, the ideas that she had to finish the thesis, it was not relevant at all. The parents found it very confusing, the way she was planning those things. And the parents felt that the boyfriend who she lived with felt that she should see a psychiatrist, because there has been a changes since starting of methylphenidate 30 mg. And after she consulted a psychiatrist there, they have stopped methylphenidate, and they started around quetiapine 25 mg for sleep disturbance. However, the symptoms did not resolve. There was status quo in terms of the way she presented. And in January 2026, because she was symptomatic and already there were a lot of IPR issues with the boyfriend, they broke up. This added to the already existing stressor that she had. And what happened was, in February 2026, the sleep cycle, it got more disrupted. She started sleeping for only 3 to 4 hours, and her speech output increased. The verbal aggression, irritability, everything got increased. And apart from that, she started becoming more over familiar. She started hanging out with strangers, with homeless people, and she started spending more money. So this was not her before the methylphenidate. These things came into the picture after starting methylphenidate and after the breakup with her boyfriend. And in March 2026, the parents were in constant touch with her. They used to speak to her over a call. They were also in touch with her friends also, just to see how she was doing. They were quite worried since almost 1.5 months, the way she was behaving. So the father decided the mother and father, they lived in India. So they decided they have to go back to Amsterdam and just check on her how things are going on. They felt she needed treatment, she needed some kind of intervention, and that's what happened. In March, father flew to Amsterdam, and he convinced her that she should, because see, first they wanted to see a psychiatrist in Netherlands at this point of time, but it is very difficult in overseas countries to get a psychiatrist appointment. She was still on the wait list because they considered that there was no emergency at this point of time, so she was still on the wait list. So the father decided, let us get her back to India and let us get treated in India. So she agreed for that, not for the treatment. The father said, let's go back to India, let's see grandparents. You have not seen your grandparents for a very long time. So he convinced the patient, and they flew back to India. They landed in Mumbai airport. So what happened was, again, because she was symptomatic, she started becoming aggressive in Mumbai airport. The plan was to go to Mangaluru, to catch a flight to Mangaluru from Mumbai, but that did not happen. She started demanding that she wants to go to Bangalore and see her friends in Bangalore. The father could not control her, and he was okay with it. And she did take a flight to Bangalore from Mumbai, and she did not allow the father to accompany with her. The father was also not able to get in touch with her over the phone. So what father did was, he knew her friends in Bangalore, and he reached out to her friends in Bangalore, and they reported that she did come to them, and then she started becoming more intoxicated, started consuming cannabis, and she became aggressive. They started threatening to harm herself. All these things happened while she was with her friends in Bangalore. The father reached out to a psychiatrist, and the condition, the state that she was in, she had to be hospitalized. And under Section 94 and 89, we did get her into our facility, and we started the inpatient psychiatric care. Now, I'll talk about the past history that I have. In 2024, while she was working on her thesis, she was not able to complete it, and she was lagging behind in her academics. So at that point of time, she started having low mood, anxiety, anhedonia, easy fatigability, and all those things. And she was treated for the same with escitalopram 20 mg. And that's the past history. When it comes to family history, both parents have cluster C traits. Because I interacted with them a lot, and they did come across as, both of them, OCPD, anxious, avoidant kind of traits were there. Now, in terms of developmental history, I did not get much here which can add on to this case, but it's quite interesting when we go forward how she was diagnosed with the other disorders, wherein there should be a significant contribution in developmental history. Now, coming to pre-morbid personality, she's emotionally sensitive, impulsivity was there, unstable relationships, there was social inhibition, fear of criticism and rejection. All these things were there in terms of pre-morbid personality. Now, some of the other history that I wanted to mention was, she actively used marijuana, nicotine, and alcohol. Alcohol use was to a level of harmful use, and nicotine and marijuana dependence was there. And she also had difficulty focusing on complex tasks. She had forgetfulness, losing things, procrastination, impulsive spending. All those things were also there. She did have social exhaustion, restricted interests in terms of just reading a certain kind of books and watching animes, and there was selective eating. She actively avoided certain food items when it comes to the texture of the food. She did get overwhelmed when she was in crowded places and when there was a lot of noise. Now, the way she coped up with stressful situation was, she used to eat less or completely avoided the food when she was stressed out. In MSc, what I found out first 1 week was, there was an increased psychomotor activity, increased rate and volume of speech, mood and affect was elated, flight of ideas and thought, impaired judgment, and insight was grade 1. So, Gopal sir, this is my history presentation. If there are any questions or clarifications here, we can go ahead, sir.
Thank you, Dr. Vishakh. So, I see many postgraduates and young psychiatrists here. So, can at this point, there was a beautiful flow of the history that was narrated by Dr. Vishakh. Are there anyone who would like to come to a differential diagnosis at this point of time? Maybe we can discuss in 1 or 2 minutes. Is it fine? Anyone who would like to contribute at this stage? Am I audible?
Yes, you are audible, Gopal.
So there's a young female who presented with features of increased activity and risky behaviors. In the background, that she was diagnosed with ADHD and started on a stimulant. This is a very brief summary, and there is a past history of something similar to mood symptoms. And there is a temperamental vulnerability, and there is a family history of cluster C traits. With this background, maybe we could contemplate some of the differential diagnosis this stage. If anyone would like to contribute. If not, we'll proceed with Dr. Vishakh. Maybe if we can see further how the workup takes turn, and we can proceed with discussions of how diagnostic formulation and then the management happened. Maybe anyone? Yeah.
Somebody has put it in the chat box.
Yeah. So I couldn't identify the name. There's a text response saying BPAD. Anyone else? Is there any other differential diagnosis? There is history of substance use as well. Are we dealing with only BPAD, or is there anything more to the case? Okay, can we proceed, Dr. Vishakh? You can continue the rest of the case presentation, and we'll open up the forum for discussion after your rest of the presentation.
People can post their questions in chat box so that we can read it out at the end and we'll clarify your doubts.
So one of the diagnoses that was put was BPAD.
Yes,
right.
Yeah.
All right. So these are some of the differential diagnoses that we can think of. Bipolar disorder type 1 that somebody had already mentioned, and there is a substance use disorder considering she's been using cannabis and alcohol and nicotine. Somewhere down the line in relevant history, I also mentioned about her how socially she get exhausted very soon, and her picky. She has been a picky eater. How she had a sensory issues and she avoided crowds. So maybe we can think of autism spectrum disorder. Also, I had put in premorbid personality, mainly mentioning her cluster P and cluster C traits. So we can think of that also, and ADHD, because there was a lack of focus, attention, concentration, forgetfulness, all those things were there. These can be our differential diagnosis. Okay, So I'll just jump to the course of management in the hospital. But now that we have all this differential diagnosis, can we also discuss how can we manage this case, sir? Like if anyone can, any inputs from PGs about how we can manage this case psychopharmacologically and psychosocial management?
And also, if anyone have any comments about the differential diagnosis, whether they are thinking along similar lines or different, any pros and cons, or any evidence that supports or does not support these differentials, please feel free to comment and ask questions.
Anyone from the participants would like to discuss upon the differentials? You can also put a text in the chat box so that we could be able to read it and bring it to the discussion.
The ASD and ASD have mentioned as differential diagnosis, but developmental history was nil significant. Can there be a possibility to still consider these two as TTs when there is no contributory developmental history?
I think that's the question we need to explore, right? When somebody is acutely unwell with manic symptoms, maybe we cannot rule out all these neurodevelopmental issues, but at least we should be a little open to the possibilities of those when there is particularly collateral history suggestive towards some of these impairments during development from parents and other sources. So that's what we have put it here. Of course, we may not be able to diagnose this neurodevelopmental during acute care admission, but something we should be open to if there are any suggestive manifestations. That's why we've included everything. Of course, this need a lot more workup, maybe post discharge when she is a lot more settled, a lot more digging into the past history, developmental history, and all that. But these were some of the indications for us when we saw her here. Yes, Smitha, did you like to add?
No, that's primarily, I think the challenge that we faced is that when she came in, it was very clearly mania. And through the course of her stay in the hospital, once the manic symptoms started settling down, we noticed that she was also very particular about things such as timings of sessions. She wanted our therapy at 1 o'clock. She had to have it at 1 o'clock, and we could see that irritability starting. And initially, though we ascribed that irritability to be some residual manic symptom, it was not going along full syndrome of a mania at that point in time. And she had already gotten better. She was taking medicines. We also noticed that she was she had very particular interests and very stereotyped in nature. And that at that point is when we began to suspect whether the previous diagnosis that she had received in the Netherlands of ADHD and possibly an autism was actually fitting the case. And it brought us to the question of how much a developmental disorder would influence the presentation of a condition such as mania, and the other way around also. How much would a manic episode influence the assessment and the evaluation and the intervention for a developmental disorder? Of course, the bigger, broader question for us all to ask is how common is the comorbidity? How often do we make this diagnosis? And how often do we factor all of this in when we are seeing patients with what we think is a straightforward case of mania? So, of course, I think Vishakh will tell us what we did while she was here. But just to give everybody an overview of what happened.
So initially she was aggressive, sleep cycle was disturbed, irritability was there. So we had to manage her with SOS injectables, haloperidol and lorazepam 5 mg and 4 mg respectively. Along with that, we started an antipsychotic mood stabilizer. We as a monotherapy, we started with 5 mg and escalated the dosage until 20 mg. However, when the YMRS score, we were tracking the YMRS score, there was not much symptomatic improvement when we did. We just used olanzapine as a monotherapeutic drug, and then what we did was we added sodium valproate as a mood stabilizer. Started with 500 mg, increased to 1000 mg, of course monitoring the serum valproate and ammonia levels periodically. Then we started noticing there was a improvement in her symptoms. While she was in acute phase, our clinical psychologist mainly focused on YMRS, and then supportive therapy was done while she was in acute phase. Our family therapist did speak to the parents and worked on expressed emotions of the parents. And also they were quite anxious the way things were going on. So our family therapist worked with the parents. Eventually, when she started getting symptomatically better, so in Sukoon, we have this clinical program. We have different mental health professionals. So in terms of physical activity, we have yoga sessions, and we have gym, and we have art therapists. We also have occupational therapists, apart from, of course, counseling psychologists, family therapists, and clinical psychologists. So we have this multidisciplinary team who actively works with both the family and the patient. So in acute phase, just 3 or 4 professionals were involved, and once she started getting better, she did engage in art therapy. She also engaged in occupational therapy sessions, and she started doing yoga, and all of that happened. Also, when she started becoming symptomatically better, what we observed was her anxiety came out. We could, like Smitha Manjunath was saying, most of her query autistic symptoms where we could notice that, and her personality factors were also coming out. So in Sukoon, what we do is, after the admission of a patient, at least 1 to 2 times in a week, we do multidisciplinary team meetings. So how it goes is, first we discuss the initial findings and what is the treatment plan that is going to happen for the next 4 days. So we meet over and over again to refine our treatment plan in terms of psychopharmacology as well as psychosocial management. So here in this case, we did liaise with the mental health professionals of Netherlands also, because they were the first treatment. I mean, primarily she was getting the treatment from a psychiatrist in Netherlands. So we did conduct at least 2 to 3 MDTs with the psychiatrist and psychologist in Netherlands. And over a period of time, what I observed was, after she was better, after she came out of that acute phase, she was also comfortable talking to the clinical psychologist in Netherlands. So 3 times in a week, we did arrange a session for her with the clinical psychologist who was living in the Netherlands. So that actually helped her, talking with our professionals as well as somebody who was in the Netherlands. The clinical psychologist was also in touch with her. So this is how we manage this case. And any doubts, anything that any questions here?
Just want to add a couple of points to what Dr. Vishakh said. At Sukoon, what we do is, the patient's journey typically at Sukoon is divided into 3 phases. We call that program A2R plus, acute to recovery, and the plus symbol stands for beyond recovery. The idea of these 3 phases is, the 3 phases, by the way, are called acute, stabilize, and embed. The idea of these 3 phases is, each member of the MPT, like Dr. Vishakh mentioned about the complete multidisciplinary team involved in every single patient's care. Each member of the team will have certain goals set for themselves with the patient in each phase, so that we want to transparently track those goals, monitor the progress, whether we achieve or not achieve for whatever scientific reason, and we want to involve the family members. So these MDTs Dr. Vishakh mentioned is to discuss the progress with evidence and with the goals set for each member of MDT. And this happens virtually, where the family members, the referral doctors, and even in this case, people from Netherlands joined virtually. So the psychologists there, right?
Psychologists and psychiatrists
both joined virtually. It was a very helpful discussion to get their context. So that's the idea. So this is a very collaborative way of working. It's something students would be interested to know. The collaborative working has its huge advantage of knowing the background. In this case, some of the challenges which Dr. Vishakh will talk about in a minute, yet not just the clinical aspect. I think he'll get into the cultural aspects. You'll see why those things were very, very significant in this case.
Sir, I have a doubt.
Yeah, please. Yeah.
Sir, considering the current episode being triggered by the use of methylphenidate, should we consider it as a drug-induced switch? Because patient was earlier treated for a depressive episode in 2024 with escitalopram. And will the category, I mean, for theoretical purpose, will the category of BPID changes drug-induced switch?
Yeah.
Yeah, that is one of the things that we did consider, Dr. Suresh. But for us, when she presented, she did present with the whole syndrome of mania. So the one thing is, and when we went back and checked her history, there seem to have been episodes of similar nature, possibly attenuated for a shorter duration, even without methylphenidate being in the picture, and sometimes even without substances being in the picture. So the two differentials that we had were a proper manic episode in the context of a bipolar 1 type of picture with a prior depressive episode. The other differential was a drug-induced switch. But of course, what we expected is that withdrawal of the methylphenidate should cause some resolution of symptoms. And she had not been on methylphenidate for some time, in the course of a presentation, from traveling from the Netherlands to coming to India, her not being, I think Vishakh did say she tried to come to Bangalore, wanted to go to Bangalore. She was missing. In fact, she was not in the system for a couple of days, and so all of this took at least 1 weeks. And you expect that once you withdraw methylphenidate as a drug-induced switch, you do see some attenuation of symptoms, which we did not really find as no case. The other differential, of course, to be considered is something substance-related. And again, very interesting. I think when we come to the cultural aspects, you'll realize that cannabis is far easily accessible in the Netherlands. Of course, it's legal, and that's another challenge that we faced going on. But given that there was a clear-cut prior depressive episode, there was also a full syndromal manic episode with possible prior attenuated manic symptoms in the past. We went ahead with the diagnosis of a bipolar type 1. The other thing to consider is, by considering it as a drug-induced switch, would we be under-treating her? And that is a distinct possibility when it comes to clinical care delivery. And given that she presented at a severe level of risk in terms of the risk of vulnerability, the risk of aggression, I thought it was better to overstep my bounds and consider it a type 1 bipolar disorder than go with the type 2 types.
Thank you. Thank you.
So the clinical challenges here were it was a dual diagnosis considering her substance use and bipolar disorder. And some of the signs and symptoms were overlapping between ADHD, ASD, and personality disorder. Like, for example, her social inhibition and her anxious traits. So this is very commonly seen in ASD and also cluster C traits. And again, the fact that she's a very impulsive, that can be again part of ADHD or cluster B trait. So in this way, there were a lot of overlapping signs and symptoms, and very difficult to reach to a diagnosis apart from bipolar. And also, when there is a developmental disorder, and on top of that, if there is an axis 1 disorder, it becomes quite complicated to treat it, and the prognosis is quite guarded when it comes as an axis 1 disorder. So those were the clinical challenges that we had to face. And legal challenges were, so somebody who is a citizen overseas and we are admitting them here in India, so we have to follow some of the protocols of foreign national patients, which basically involves giving an intimation to FRRO and involving the embassy, especially when it is a section 89 and 94 admission. So these are the things that we have to do. Explicitly in MHCA, nothing of these things, I don't think so it is mentioned, but these are things that we follow. And after once she started getting recovered, we were in constant touch with the Dutch embassy, and we planned a repatriation. So what happens is when she goes back to Netherlands, she either gets treated in a community wherein the nursing staff and clinical psychologists come and check on her, and she also has OPD follow-ups, or she again gets shifted to another institute in Netherlands, wherein the inpatient care continues. These are the two things that we had to decide on, and then give a fitness to fly certificate. Insurance policy was a Dutch insurance policy, and this cross country, accepting this insurance and working with it was also difficult. But however, they were cooperative, and we did have a lot of meetings with the insurance team, and we got it all cleared.
So at this point, and I would like to come in, I don't know how to see the slides and also see everyone. Maybe I'll minimize this for a minute. I don't know. Technological. Oh, yeah, now I can. Okay. Hope you guys can still see the screen. So I think for PG students, I want to spend 5 minutes on discussing this aspect of our presentation, because clinical challenges, I'm sure you come across these kind of scenarios quite often. The coexisting substance misuse, diagnosis, bipolar, and all that. But I think legal challenges, particularly in the private sector, I think I want to spend few minutes in discussing this. One, maybe I could ask this question, maybe if anybody wants to answer in chat box or raise their hands and say, when a foreign national is in India, right, and if they are severely mentally unwell, acutely unwell, posing some risk, no insight, and no capacity to decide, how do we proceed? Does anyone want to answer this question? A foreign national in India, acutely unwell with no capacity, no insight, doesn't want treatment. Oh, here it is. I think we should stop sharing.
Anyone from the participants would like to answer to Dr. Satish's question?
Well, of course, you can put your comments or answers in the chat box also. Look, while you come up with any doubts or you're sharing your experience, let me explain a couple of things. Particularly for emergency treatment, right? The law of the land applies. Irrespective of where you are from, which country you are from, and what visa you are in, it does not matter. Particularly if they are in emergency, acutely unwell, and posing some kind of risk, the law of the land applies. So it's easy to navigate the Section 94. I think most of you will know what Section 94 of Mental Health Act 2017 is. The section for emergency treatment. With the criteria, of course, is very stringent. It talks about to prevent any death or irreversible, harm or serious harm to self or others, and things like that. Of course, you can justify that when somebody is so acutely unwell and posing so much of risk of aggression and vulnerability and things like that. Because there is no other way of treating them in the community safely, no other option is viable. This is fine. But in terms of practicing Section 94, as you probably would know, yes, consent would be helpful from a nominated representative, but it's not mandatory. And Section 94 also involves transferring patient from wherever they are to nearest mental health establishment. So this is exactly what we did. Now, what happened? Of course, we didn't go into the details of where she's from and all. Later, we realized, of course, she's Dutch national. She's on whatever visa, OCI card. I don't know. Was she an OCI card or not sure?
She's an
OCI card. So we got her into the hospital. Then what the next step we do is, of course, the consequence of Section 94 assessment, making her section into Section 86 or 89 or discharge. That's a clinical consequence. But from a visa standpoint, we as a hospital, we have a responsibility to inform the FRRO. FRRO I think it stands for Foreign Registration Office. It's the government of India.
Foreign Registration.
Foreign Registration Regulatory Authority. It's the government of India, Ministry of External Affairs, where they'll take a note of this person who is in our hospital and inform the relevant embassy. Then the relevant embassy have a right to come and see the welfare and well-being of their citizen in our hospital. Many times we've had visits of this embassy people to our hospital from foreign nationals when they're admitted here. They want to make sure that they are in the right place, they are treated well in a safe, dignified manner and in a very legal manner. So that's the learning for the students here. To inform the FRRO, and the FRRO informs the embassy, and the embassy can actually visit us. And in terms of the treatment, of course, if they're on, as long as they're in Mental Health Care Act, we carry on treating them as I said before, the law of the land applies. Following stabilization, we of course we need to discuss with the family and the patient in terms of where they prefer to carry on the treatment, and they can be sent back to their country. Ideally, we inform the embassy as well about the discharge, and also the clinical team in Netherlands. That's exactly what our clinical team did in this case. Involved the Netherlands Mental Health Services through the admission for the FDT meeting, they got involved. So that's something I wanted to highlight. If people come for elective treatment for mental health, they may need medical visa with the new rules. But emergency treatment, the law of the land applies.
Thank you, sir. I just have a question. Suppose if this patient, how within what time frame that we are supposed to inform to FRRO? Like Section 94 gives us 72 hours of time, and what is the timeline that usually we are supposed to inform?
No, normally we do it same day. We don't want to waste any time. So I don't know if there is a specified 24 hours. Okay, that's Smitha says 24 hours. But
24 hours. Okay.
Earlier the better, because imagine if something untoward happens to this patient when they are in the hospital, maybe because of medical consequence or something. Of course, we will be held responsible for not informing the relevant embassy. So we do it same day we inform.
Is there any how do we usually contact, sir? Is it over a documentation, email, or just over a phone? How is the contact established usually from the hospital?
There is a preset form that they have. We need to fill in the particulars, and there's an email that we send it to. So this is an intimation that a foreign national has been admitted with us, so that they can then pass on the information to the relevant embassy. From what I understand, they are not very particular about the clinical aspects of it. That a foreign national is requiring hospitalization is what they want to know. Of course, the embassy can take a call on how and like Dr. Satish was saying, we have had instances with other patients where the embassy has actually come to the hospital to check in on the welfare of their citizens. But the FRRO, it's an intimation that a foreign national is admitted. They are not too particular about clinical details, and they're not worried about the other aspects of clinical care. So it's just with respect to their name, age, particulars in their passport. Those are the things that we need to fill in and send off.
Not related to this case, but I would like to add one more point again from my previous experience. Again, it will be good learning for students. We had a foreign national who was admitted here under Mental Health Act when we didn't have NR. There was no NR in the country to give consent. We couldn't track any nominated representative to their own home country. So in those circumstances, we do expect the embassy to take the role of NR. So we inform the embassy, and the embassy will have to they'll have to come here and act as nominated representatives. Somebody will have to be there, particularly for 89. 94 we may not need, but for 89 we certainly need.
Thank you, sir. You actually answered my next question also. Suppose the contacting embassy and sending their representatives, what if there is any inadvertent delay? Is there anyone from our department, like Foreign Affairs or anyone who can be kind of ad hoc NR before? Suppose if we have to convert it to 89 from 94, and the embassy couldn't be sending any representatives. In such case, what would be the likely action that we can do?
Yeah, no, it's a good question. Look, honestly, I don't know what the right answer is, but I can share again another experience. We had a very interesting case again, coincidentally from Netherlands itself. Uh, this patient was like a destitute in an orphanage. An auto driver had taken her and admitted her in an orphanage. Apparently, she was a Dutch national, having no one. She had got some help from Dutch embassy for some help. After that, they gave up because they couldn't send her back to Holland. So they left her. I don't know how it happened, but eventually we figured out that she didn't get any help. So somebody contacted us and we had to admit her here in at Sukoon, and she had no nominated representative. We didn't know who was going to pay for her admission, being in a private psychiatry. That, as you could imagine, that's also important. And so we admitted her as a goodwill, started treating her, and we approached the embassy to explain the situation to them. And they, as you rightly said, they delayed in coming here and seeing her and signing the nominated representative forms because we couldn't even track her family in Netherlands. So in those circumstances, our only safeguard is we document everything and we act in patient's best interest, and we write the emails. Even if you don't get the response, that's fine, but we keep all the emails that we informed all the relevant authorities, and we continue to treat the patient in their best interest. I think that's the best answer I could give. We don't know the right answer, but we do what's best for the patient.
Thank you, sir. Is there any role that MHRB and the state mental health, this one, MHA has any role to play in this? Should we inform these kind of patient cases to MHRB?
No, 100%. We definitely do inform all mental health act proceedings in the hospital to MHRB, section 94, 89, 90, everything, and within the time frame. And this case also we inform. But as you know, currently the functionality of MHRB is little low. I think at least in Bangalore, I don't know about other districts. So I think they have multiple roles they're handling. So it's timely response may not be there, but we keep them informed. We definitely, just like the FRRO on the embassy, we also informed the MHRB about the status of this patient, kept all our documents and the emails as part of our safeguard.
Maybe MHRB can be appraised about such scenarios, and maybe we can expect some more readiness from MHRB to act before, or if there is any delay from embassies. Maybe IPSKC office bearers here may take a note of this, and we can appraise MHRBs and whoever who can work in this area. This is a good discussion that we had. This particular scenario differs from the routine patients we see in any other hospitals, because there is a foreign national involved and the possibility of Section 89 is here. I'm just wanted to ask one more last question. I just wanted to know for the participant's sake also, what was the final diagnosis was made, and what was the section under which her hospital stay was continued, just for clarification.
Final diagnosis remained bipolar disorder of mania. And
Okay.
yeah, that is our primary diagnosis. But like I was saying, as symptoms settled down, we did get the suspicion of whether there was an underlying developmental disorder, but we thought it was not the right time to make an assessment of it. She's just recovering from a manic episode. We thought that could hold on. In any case, in terms of continuity of care, it was quite clear that this patient chose to go back to the Netherlands for long-term settling, and she was in India for other reasons. So even in terms of intervention for developmental disorders, we were not sure of initiating it, because then again, how much are we going to be able to contribute to a longer-term care? And I think I'm sure Vishakh will tell us in the next slide, but they were also a little sections in the second part. Yeah, the second part section, she was under Section 89. So the parents are Indian nationals. They have a dual citizenship. So they were NR. The mother was the NR for this patient.
That was one thing that was in the favor of treating him. So it was amicably. So any more questions from the participants regarding the discussions held right now? Any clarifications? Any questions?
So we haven't completed the triad. There's one more triad part of the triad.
Yeah.
Yeah, that's also interesting. In this case, I like Dr. Vishakh conducts with that.
We'll go ahead then. Dr. Vishakh, please take over and continue.
Yes.
The next pillar of the triad.
Some of the cultural challenges that we faced were the explanatory model of illness, because even after she came out from acute phase, the clinical team felt that she still needs to be treated, but she did not feel like that. She was, the patient was feeling that she had the authority to now decide her own treatment course and all of that, because that's how the Dutch team works, the mental health professionals in the Dutch work. So
involved with the family.
So that was also one of the things, because they don't communicate much with the family, the mental health professionals in Dutch. So we had to somehow convince her and keep her for a more number of days until we felt she's safe when she gets discharged. But that's something that we faced as a challenge, because repeatedly she used to bring up the point that now, like, I have the authority to choose my medications and all of that. And one is the communication style. Initially what happened was, when she was asking for discharge, sometimes we get frustrated. We say that, okay, you will get discharged soon. We don't give her the clear date and time. So she prefers that. She prefers on what day I'll be discharged, what is the time. So we were not straightforward, which I realized later that we should have been, because that's how the communication style in Dutch is. They want a straightforward answer. They don't want us to beat around the bush and give them false promises. So that is something where we faced a challenge. And in terms of getting adjusted with the environment and the food, those things were also there. These were some of the cultural challenges that we had faced while treating.
Do you want to highlight anything?
Yeah, I think, at least for me, my biggest learning was what we practice as psychiatry over here in India is so different from the rest of the world. I haven't had the experience of any other place except India. But then what I realized in Netherlands, it seems that most mental health care is very self-deterministic, very driven towards patient autonomy. And like Vishakh was saying, they get to choose or they get to have say in everything, including admissions, which compares to the Indian Mental Health Care Act, which is, while being very rights-based, is also family-heavy. And a lot of our discharge procedures, a lot of our admission procedures involve family. And I think this is, in a lot of ways, our safeguard in India, that we have a support system, we have a family to discharge patients to. We have somebody who will stand in as an NR, and we are not often relying on public health systems to give us that. Imagine if we had to approach the MHRD for assigning an NR to every patient of ours, that would really be difficult for treating patients. So that kind of a very contrast. For the parents too, who have grown up in India, who have spent a long time in India before migrating, they also inherently have the notion that they're very much part of any treatment for their ward and child. And that's how they saw it. So they were expecting a lot of information from the Dutch mental health system. So they were very shocked to find that they were not given admittance to meet the psychiatrist in the Dutch hospital. And they were up in arms about it. And why it was so easy for them to access care over here. They can walk up to any psychiatrist, and the Indian Mental Health Care Act jurisdiction extends to every place within the territory of India, not just to Indian citizens. So we found that the parents were very, they had great difficulty adjusting to the Dutch mental health system. Of course, they found it reassuring, but we also have to weigh in the fact that the patient herself identifies more as a Dutch citizen, although she is of Indian origin, but it's been long since she's really associated with much of Indian systems of health or culture, and her interaction with India was mostly when she came for visits to her grandparents. So, that is again a contrast that really played out.
So here I would like to add another point because I had the privilege of working in the UK, which is very similar to some of the European countries. I think the reason in as long as the mental health act admission, it still revolves around the capacity and the risk. And there also we need an NR, and more often the NR role is taken over by the social services department if the family are not accessible or not available and things like that. Now, once the patient passes that phase of being acutely unwell and they regain some capacity to decide for themselves, then, like Dr. Smitha was saying, a lot of focus will be on the patient autonomy and their own decision. The reason being, culturally also, the family are there, but they may not be closely involved in the entire care plan. And secondly, they have an excellent community services. The Western world, they have every small village or town will have a community mental health team. When the patient gets discharged from acute ward, the CMST and the community mental health team will take over the care. They make their care plan very robust, like almost like daily visits, social worker getting into action, occupation therapist getting into action. So they take over the role of the family to keep the patient safe in the community and also for the functional recovery, community reintegration and everything. So that's the reason why the patients will have the autonomy to choose. But here we rely a lot on the family. So this family were coming from that space of, okay, yeah, we want to be involved because we want to support our child. They call, although she's an adult. Whereas this girl was thinking that she's a Dutch national and she has all the autonomy, all the right to choose how she needs to be treated, not just in hospital, but in the community. So this was the issue we had to deal with, but I think our team navigated it very well, getting the family and the Netherlands team involved. The transition was quite smooth.
Thank you, sir, for summing up well. We'll have discussions on all the three triads that are described. Anyone from the participants who would like to add something from their experience or have any questions regarding this? You can even put your questions in the chat box or raise a hand so that we'll be able to take up that question. I guess there are no texts as well as any questions. Dr. Suresh, can we proceed to sum up the session?
Yes.
So I just want to say that, people who want to reach out to us for, discussing this case or any other aspects of private practice in an acute setting, the challenges, we are more than happy to talk to them, share our experience. People can come and visit our place in Sukoon Psychiatry Center on New Bell Road in Bangalore. If anybody wants to get in touch with us or come and visit our place to understand how our clinical model is and the kind of patients we treat.
Sir, hello, sir.
Yeah.
Yes, Dr. Vinay.
I'm Dr. Vinay. Actually, I had a patient like say 1 year ago, sir. It was a bipolar disorder case only, but the patient was from Canada. She was NRI. From the past few years, she has been staying in Canada, and she was diagnosed with BPAD. She was put on treatment, and lastly, she was on lithium 300 mg, sir, VD. But then there, it was difficult for her to follow up and all because she had to take appointment 6 months earlier. So it was a little difficult for her to follow up. So when she was visiting India, she had come to me. So I had seen the patient. She was maintaining well, there were no issues as such. She was asymptomatic at that point in time. So I was trying to titrate it down and stop it eventually. But later on, again, she wanted to go back. So, like she was just visiting her hometown here in India, and she was planning to go back after a month. So it was difficult to follow or make any decisions about the management plan. In this kind of a situation, what can we do, sir?
You know,
I mean, it's international. She's going to be staying in Canada, and I am in India. So it will be difficult for her to come down only for consultation, like which was almost the same situation came out to be the similar situation which was facing in Canada also.
yeah, no, thank you,
If
Dr.
not this patient, in case if there's any symptomatic patient also.
Sure.
And there was one more case. The patient was here only. I had started her on treatment. She was improving with the medications, but then she got married and she had to relocate to US. So again, it was difficult to follow up again. So right now I was like, there was no other option, so I could not continue the consultations further. So I just thought maybe I'll get some help here about that.
Sure, Dr. Vinay. Thank you for the question. Very, very apt question, because we see, I'm sure every clinician in India will have patients who are living
Yes, sir.
abroad or moved abroad
Yes,
or
sir.
abroad, right? So I think
Yes, sir.
2-3 aspects here. One, I think we need to ask ourselves, are we able to provide a comprehensive treatment for this patient while being abroad, right? Of course, there is a telemedicine guidelines and things like that, for your consultation for patients who are connecting virtually abroad and all that. But the general principle is, are we able to provide the best care for, particularly for these kind of chronic enduring conditions like bipolar, where patients may need very robust care, crisis management plan, if they relapse, what happens, and all those things. It's better to always encourage them to get in touch with the services wherever they are living in, and get help there. As a, maybe clinician who's been treating this patient for some time, you can be in touch, and maybe as a second opinion, other support you can provide. But my suggestion is you ask them to go and get in touch with the services there locally, particularly for chronic, psychotic illnesses conditions. But there are a lot of patients who have maybe mild neurotic conditions who are very comfortable talking to Indian doctors from a cultural connectedness point of view. We have lots of such patients who don't want to go to the psychiatrist there. Maybe there are practical challenges of accessing care. It's not easy. There may be waiting period of 6 months. They're not happy with the therapist because they're not able to culturally connect. There are lots of such issues. I think in principle, we try to help those patients by helping them with this consultation, but the challenge will be the prescription. The biggest challenge is the prescription, because as you know, our prescription will not hold good because they're not registered there. What I tell some of my patients is, look, I suggest option number one, go and seek a psychiatrist's opinion there. If they're not willing to do that, I'm happy to consult. Maybe for repeat prescriptions, if they are stable, with all the restrictions of prescribing certain drugs like benzos and things like that, we ask them to take my prescription to the local GP there and tell them, look, I'm getting this consultation from this doctor in India, and this is what they prescribe. Based on this prescription, would you be happy to give me a repeat prescription? And many general practitioners in Australia, UK have respected that and have given the repeat prescription to them. These are for mild neurotic conditions only. And for therapies, of course, they see psychologists here. But for serious mental illnesses, chronic conditions, I always suggest them to get in touch with the services there.
Sir, one more doubt, sir.
Yeah.
Hello, sir.
Yeah, please go ahead.
So one more doubt. Is there anything like we have here telepsychiatry or telemedicine, right, sir, locally?
Telemedicine guidelines.
No, sir. As in similar to that, is there any other guidelines where we can attend to our international patients also?
No, not as not in my knowledge. Also, most of these, there's also the legal aspect. I think whatever guidelines we come up with is particular to telepsychiatry, is particular to the practice that is done here in India. So the challenge is really about prescribing medications. And just to add to what Dr. Satish said, if I were to see somebody at a cross section at this point in time in India, although they're not staying in India for whatever reason, And I do feel that they require some care, and I can provide that for the time that they're here. Can I provide continuity of care? I don't know. And that's for, again, patients and family to discuss and reach out to their own services back in whichever country they are. So, have I given prescriptions to people in India who are either foreign citizens or have come in an emergency? Emergency is quite clear, you can. But otherwise, Indians who are staying abroad, of course, I think as long as they're here, I have given them medications also. But like Dr. Satish was saying, it's good for them to reach out to their own general practitioners back at home. And at least, I think, at least a couple of my patients do that. They take the prescription, I give them, and reach out to their GPs back in Canada, US. And luckily for them, they have nice GPs, I think, who's been prescribing the medications. Yeah, I hope that answers that question.
Hi, ma'am. Thank you, ma'am. Thank you for the response.
Are there any other questions from audience? I think we can proceed with summing up. Thank you, sir. This one treating international patients is always a difficult decision to make. There are a lot of patients who start treatment here and would go out and they say they'll come back. They want to carry some medication prescribed here, though they are not physically here. They come up with so many suggestions. And Dr. Smitha, thank you for clarifying. It's always safe to uh, treat them when they are, as long as they are here. And if they land up into some trouble, maybe adverse effects that may not go really well with the emergencies in the other countries, because you are not a recognized practitioner in any other country. So just to take this important message, especially for early career and psychiatrists and those who want to go out and practice or uh, treat a lot of international patients or NRIs. So this, Dr. Vishakh, thank you for presenting a beautiful narrated case. There's a young female who is not an Indian national, but rooted here and presented with probably mood episode and other affective symptoms in the background of probable neurodevelopmental disorders and substance use. There are multiple things which can confuse the diagnosis. So the first diagnostic challenge is what would be the first working diagnosis, and the next is legal. Whenever we are treating international patients, NRIs, and this legal hassle will always be there for who is going to take up the responsibility, especially so when when there is no family or kith or kin. And the third is the cultural, that is much more deeper, where even if we solve these first two hassles, the third one becomes the real important, where the interpretation and the continued care becomes challenging. So, to sum up, uh, this case gives us much insights on not only diagnostic challenge, the other two challenges becomes important in management and continued care. Uh, Thank you, Team Sukoon, uh, for presenting such a nice, insightful, and unique case which has different challenges. I hand over to Dr. Suresh.
Yeah, on behalf of IPSKC, I would like to thank Sukoon Psychiatry Center, especially Dr. Vishakh, Dr. Satish Ramaiah sir, Dr. Smitha, and moderator for today's session, Dr. Gopal Das, for bringing about wonderful discussion and lot of learning from this case, even for us also, not only for postgraduates, for us as a consultant in dealing with so many cases in and around us, which we tend to happen more frequently. At least we tend to hear from so many people. And thanks for wonderful discussion. And with this, we'll conclude the PG session.
Thank you, Dr. Suresh. Thank you, Dr. Gopal. Thank you, everyone.
Thank you, sir.
Thank you all.